Salam sejahtera dan selamat pagi. Saya, Catherine Tay, merupakan pengacara majlis pada pagi ini. Terlebih dahulu, saya ingin mengucapkan ribuan terima kasih dan tahniah kepada semua peserta khusus yang dapat meluangkan masa bersama-sama mengikuti majlis ilmu kita pada pagi ini. Bak kata pujangga, tuntutlah ilmu hingga ke liang lahat. Tuntutlah ilmu hingga ke negeri China. Semoga usaha kita semua diberkati Allah. Sesi seminar kita pada kali ini adalah anjuran Malaysia Society of Radiographer sesi 2/2023. Sayang Selasih berisi minyak, bunga cengkeh di atas jerami. Terima kasih banyak-banyak sudi datang ke majlis kami. Hadirin sekalian, sesi seminar kita pada pagi ini memfokuskan kepada bidang radioterapi yang akan membincangkan khusus tentang bahagian head and neck. Untuk mengupas lebih lanjut tentang topik seminar kita pada pagi ini, pihak penganjur telah menjemput dua orang penceramah yang sangat berpengalaman untuk menyampaikan ceramah beliau yang bertemakan Head and Neck Radiotherapy. Bagi meneruskan agenda kita pada pagi ini, suka saya memperkenalkan panel jemputan kita iaitu Puan Melissa binti Sapitang. Beliau merupakan seorang juru X-ray radioterapi yang kini bertugas di Sabah Women and Children Hospital. Beliau kini sedang meneruskan pengajian dalam Bachelor in Medical Imaging and Radiotherapy. Beliau sememangnya arif dalam bidang klinikal radiation therapy sepanjang perkhidmatan beliau. Tanpa melengahkan masa, dengan segala hormatnya saya menjemput Puan Melissa untuk menyampaikan ceramah beliau yang bertajuk Head and Neck Radiotherapy. Dengan segala hormatnya dipersilakan.
Okay, terima kasih kepada pengerusi majlis. So, hello and good day to all my fellow colleagues. I am Melissa Sapitang, and I am honored to be part of the presenter line for our second CME for MSR. So, second CME kita bertema radiotherapy head and neck. So, I would present about childhood head and neck cancer, specifically about nasopharyngeal carcinoma. I chose this topic because of the high incidence of NPC in Sabah, although maybe not so much for pediatric cases, but still. So firstly, before we start, I wanted to say a big thank you to those who tolerate and help me during this presentation preparation. Our RT bosses, my colleague, my teammates in L1, my AMU batchmate, and also to my family. Okay. So this is our content for today, a brief NPC intro, and then some sharing from our center. Okay, pediatric age in Malaysia. So this is just a clarifications, since when researching about childhood carcinoma, there is a bit of confusion among about the age, pediatric age in Malaysia. So kalau ikut akta, dia lain-lain kalau ikut akta kanak-kanak 611, and then di bawah jenayah pun dia lain juga. So for cancer classification, 0 to 14 years old is considered as pediatric. And then Malaysia also taken into statistic of the adolescent age of 15 to 19 because certain childhood cancer peak at that age lah. Okay, pediatric head and neck cancer. So it is counted as very rare tumor in children by the US and also by the European Cancer Society lah. So this is the list of head and neck cancer in pediatric: olfactory neuroblastoma, laryngeal carcinoma, NPC, oral cavity, salivary gland tumors, which may occur after treatment to the primary leukemia or solid tumor. Okay, here is a table where we can see other very rare tumor that is registered by the European National Society lah. Other than head and neck, there is also other cancer. So now let's see some statistics before we go about NPC itself. So NPC incidence is high in Asian country, North Africa, and then is mainly happens among the Cantonese in China, and then Chinese in Malaysia, and then specifically Kadazan Dusun in Sabah. And then it is also a high incidence in males than in females lah. This is the statistic in Malaysia. So we can see it is high in males and also in the Chinese ethnic group. So in Sabah, the lifetime risk for males is 1 in 123. Kadazan Dusun, 1 in 79. Chinese, 1 in 100. And we can see in Sabah, the incidence is also high in the age group of 0 to 24 years old. Okay, so just to share the figures of head and neck cases treated in our RT department, last year we recorded 273 cases of head and neck cancer, but this is not just specifically for NPC lah, it's all the head and neck combined together. Okay, pediatric nasopharyngeal carcinoma. This is the anatomy of the nasopharynx. So nasopharynx is above the throat, behind the nose and below the brain. So when you breathe, it goes through the institution tube. The popping you felt masa naik kapal terbang take off dengan touchdown, drains through there lah. And then NPC typically start on the roof here and then on the side wall, and then it will grow downwards. And then it can interfere with the things that we talk about. It can block your ear, it can block your nose, you can have bloody nose, which is often the clinical presentation of NPC. Okay, this is the causes or the risk factors of NPC. There are two types, modifiable and environmental, which means we can see here, one of the risk factor is salt preserved fish. So modifiable means if we reduce the consumption of this food, we may also reduce the risk of getting NPC lah. So unmodifiable and genetic, that is something we cannot change, and what we can do is trying to figure out which genetic through family history to prevent, not to prevent, but to detect the cancer earlier. Okay, sign and symptom. Clinically, the most common presenting symptom of childhood NPC is cervical lymphadenopathy, the unilateral or bilateral large painless non-inflammatory cervical mass lah. Okay, it's usually more than 1 cm, then it's a concern for us, especially in childhood. So there is nasal symptom, auditory symptom, other symptoms such as headache and neck pain. And then if the tumor invade the skull base, it could result in cranial nerve palsy or difficulty with movement of the jaw. Okay, histology. This is the histology that is recognized by the WHO. So histology is mandatory for the diagnosis of NPC. because it can distinguish from other benign or malignant tumor, such as rhabdomyosarcoma and lymphoma, so we can differentiate them lah. Okay, so in children, they are more likely to have WHO type 2 or type 3 disease lah. Okay, diagnostic and staging evaluation. So investigation and imaging studies is performed to assess the disease stage, the extent of the primary tumor, and then the local regional spread, the involvement of cervical vessels and nerve. So here we can see a figure from Chuk et al. This is figure A is post-contrast T1 MRI. This is second is bone scan, and then this is plain CT. This is PET CT fusion image, and we can see the tumor clearly here lah. Okay, so okay, tumor staging. We are using the TNM system. This is the newest edition, 8th edition. So more than 90% of children and adolescents with NPC present with stage 3 or stage 4. Okay, so patients younger than 20 years had a higher incidence of advanced stage disease than did adult patients. But 10% of the children, when they are presented with stage 3 or stage 4, but there is no metastasis yet at diagnosis. So meaning they could have like T3N1MO or T3NOMO, something like that lah. Okay, this is the treatment of newly diagnosed childhood NPC. I only include the newly diagnosed childhood NPC because for relapse and refractory, there is info, but there's not so much. So this is the treatment. Treatment of NPC includes chemotherapy and radiotherapy. Due to the nature of the tumor spread and its complex anatomical location, so the primary NPC is considered as unresectable. So luckily, NPC is chemosensitive. It is also radiosensitive, and there is several studies in pediatric NPC showed good response to cisplatin-based chemotherapy regimen and is now considered as standard of care lah. So from this figure, we can see the available treatment plan could include induction chemotherapy. Induction chemotherapy is the same as neoadjuvant chemo lah. Okay, they could give like 3 courses of cisplatin, and then after that, followed by CCRT, cisplatin, and radiotherapy lah. This is the radiation prescription dose, and then it can be followed by maintenance therapy with the aim to control minimal residual disease. So this is interferon beta. It is suggested because of its antiviral and anti-tumoral properties. Okay, so the next one is treatment side effects. Okay, short term. We have short term and then long term. So short term, how short can it develop? Acute mucositis usually occurs within 1 to 2 weeks. The same with radiation dermatitis. And then for radiation dermatitis, it usually continues until 2-3 weeks after treatment lah. So acute salivary gland injury includes parotitis or swelling and pain of the parotid gland, and then xerostomia, the dryness of the oral cavity, and then making your reduce the production of your saliva lah. So long term within the first 2 years is usually thymus, chronic sinusitis, otitis media, and pulmonary fibrosis. Within 5 years of diagnosis, primary hypothyroidism can happen, and then primary hypothyroidism after 15 years of the initial diagnosis of NPC, sensory neural hearing loss, 15 years. And then if we do IMRT, there is a study that show neuroendocrine deficit because of IMRT. So visual impairment and also osteopenia is also the side effect of radiation therapy lah. And then we should talk about secondary malignancy because this is childhood carcinoma. So if we follow up with the patient, we can see if there is any secondary malignancy because secondary malignancy, there is read in a study, there is one patient, he had a secondary malignancy, basal cell carcinoma, 27 years after his first NPC diagnosis. And then 22 months later, meaning 2 years later, he developed mucoepidermoid carcinoma of his parotid gland. Okay, that is one patient. And then there is another patient. He was diagnosed with colorectal adenocarcinoma with liver mets 9 years after his NPC diagnosis. And then he developed subsequent malignancies of right maxillary SCC and then esophageal carcinoma. Okay, and then there's also a few studies that have long latency of developing secondary malignancy. There is 25 years. There is one patient developing brainstem tumor, and then thyroid adenoma, and then neck basal cell carcinoma. So secondary malignancy. Yeah, okay. So that is the treatment side effect for long term lah. Okay, prognosis. Thanks to multimodal treatment strategies, meaning the chemo and the RT, the prognosis of pediatric NPC has improved. So reach more than 90% of overall survival and progression-free survival at 5 years. Actually, for prognosis, there is a lot of studies that actually shows you, if you do this kind of regime, what kind of OS will you have? What kind of PFS will you have? But because there's too many, so I just generally put the general prognosis for NPC in childhood lah. Okay, after controlling for stage, children with NPC have significantly better outcomes than do adults. Their outcome is better than adults lah. So, but even if their outcome is better than adults, because of the use of chemo and RT, it resulted in significant acute and long-term morbidities lah, including the subsequent neoplasm, which I have talked earlier, the secondary malignancy. So radiation therapy. Along the years, we have developed into a higher technology in radiation therapy. And what we wanted to achieve when I do this slide is that we wanted to make the dose painting to be more conforms to the tumor, so that we can spare more OIR, and we can also reduce the radiation toxicity. So if we can see here, this is 2D RT, this is 3D CRT. You can see the dose painting it involves a lot of OIR lah. Okay, this is IMRT, a step better than 3D CRT, and then VMAT, then helical tomotherapy. You can see the dose is much better. And then there is proton therapy. Proton therapy, which has a better dose, rapid dose fall off. This is IMRT, and this is proton therapy lah. So we can see the dose painting is much beautiful here. So anyway, in carbon ion therapy, this is for boost in NPC. This is photon boost, and this is carbon ion boost lah. So we can see the dose is much better on this side. We can see the brainstem is spared more here. And then HDR interstitial brachytherapy. So I've never really encountered this. So yeah. So this is the evolution of our radiation treatment for head and neck carcinoma. Okay, so ongoing clinical trials. So clinical trials is important to find the better, to find solution to the things that we wanted to improve lah, like reduce toxicities and all that. So this is a study from National University Hospital in Singapore about the use of chemo in NPC patient lah. And then there is also a study. This is not yet started. Okay. I think this is in China. And then there is also almost finishing clinical trials. This is only 4 of the 16 that are found in clinicaltrial.gov lah. So just to show that clinical trials is always ongoing to find the better improvement in treating childhood or NPC itself. Okay, so case sharing from Sabah. Ngam, we are treating one NPC patient. So I just wanted to share a little bit about this patient. So he's a 12-year-old male from Sandakan, diagnosed with NPC clinically stage 3, N2, N0. So presented with submandibular swelling since July 2022 with hearing loss and then tinnitus. And then he also has on and off epistaxis. So he went to clinic kesehatan like 2 times in July and also in August. He was given antibiotic, but the mass keep on growing. So he was brought to HDOK, Hospital Duchess of Kent Sandakan, in August because of the mass over the submandibular region increase in size lah. And then so from there all the investigation is done. So he has a maternal uncle who had a NPC at 58 years old, currently on chemotherapy. So he did all this investigation, and then he started on treatment with the regime from NPC 2003. I think it's a German regime, but it's the same with this one. This one. he had 3 course of induction chemo, and then he is now ongoing CCRT with the dose of 59.4 gray in 33 fraction. Okay, and then I don't know if he's going to do the maintenance treatment. I'm not sure about that. Okay, so his management before NPC treatment. He did a dental clearance on December. He did a hearing evaluation, and also he has a nutrition management lah. Since his first chemotherapy in the ward. Okay. Okay, so this is his treatment plan. The patient is treated using IMRT with 54.9 gray over 30 weeks. So 1.8 gray per fraction. So this is the dose. And this is the DVH of the patient lah. So this is his treatment sheet. So this patient is on online review protocol, meaning in our department, if it's under online review protocol, we do CBCT daily, and then we apply shift. We apply shift for this patient and do CBCT daily. And this is his skin on fraction 13. I think the skin reaction is still on grade 0 to 1. There is no complaint of mucositis. He is tolerating radiotherapy well. And then he has a good appetite, according to his grandmother, if the food is to his liking, because this patient is a picky eater. So that's why they monitored his nutrition very closely. So management during RT nutrition, we advise on keeping a good oral hygiene, and then we gave him aqueous cream to apply on the treatment area starting from day 1 lah. This is mandatory for all patients. Okay, swatch RTT's challenges in dealing with pediatric patients. The challenges are as follows. Our facility is not really pediatric friendly, and then we only have 1 machine equipped with the facility compatible with GA, and then there is no allocated bay for children, and then maybe children is also afraid of our overall white coat syndrome. White coat syndrome can also be said as white coat hypertension, but that is for adults lah. When they see doctors and their darah pun tinggi macam tu. So kids, they are not going to have hypertension, but they will be afraid of health worker in overall. And then dealing with pediatric, we know that we need to deal with multidisciplinary teams lah. So sometimes there is miscommunication, a lot of miscommunication in our side, especially with the ward staff lah. And we said turun jam 9 and then 9:30 baru turun, something like that lah. So arrange and schedule patient according to their timing. This is with the NS sometime. But I think now our condition is our relationship with our NS is getting better. So they understand why we need this patient at this time. And yeah, something like that lah. And before this, our GA, our NS, right? They are confused. Why need to GA patient every day during treatment? It's not good for the patient. So they try to pujuk they try to console the patient, pujuk-pujuk patient supaya jangan GA lah kan. But then if you don't do the GA, when you sim with GA and then you do treatment without GA, there is difference when we do verification. This is true for all patients that suddenly doesn't want to do GA during treatment lah. Okay, but now it's getting better. They understand why we needed the GA lah. Okay, so RTT also need a high-level patience in dealing with pediatric cases lah. Okay, because yeah, we know how children are, so yeah. Okay, so what we did was that we tried to be as creative and as children-friendly as best as we could. What we did was we give them appreciation for completing their treatment. We give them sijil tamat rawatan and then toys. This is our toys box. And then we also do BDS decoration. We used to do for all range of age, but then our RTT, our main RTT who do this decoration has a lot of commitment, so we reduce the age from 5 years old and below lah. Okay, this is according to their...
Oh, baby allergic. Telur.
Okay, this is according to their favorite cartoon character.
Jarang baby allergic telur. Jarang dengar.
Okay, I think. Okay. So this is my references. And I think that's all from me. Thank you.
Okay.
Sesiapa yang on audio tu sila offkan ya. Terima kasih. Okay. Ribuan terima kasih diucapkan kepada Puan Melissa di atas perkongsian ilmu yang sangat bermakna dan bermanfaat kepada kita semua. Majlis diteruskan lagi dengan sesi soal jawab. Sebarang persoalan boleh diajukan dan menaip terus di chat box atau membuka audio mikrofon untuk bertanya kepada penceramah. Jadi jangan malu-malu, jika ada sebarang soalan boleh tanya penceramah kita. Para peserta ada sebarang soalan? Saya bagi dalam masa mungkin seminit. Boleh Puan Melissa?
Okay, boleh.
Boleh ya, kami tunggu mungkin ada soalan tapi para peserta tengah berfikir. Okey, Puan Melissa, kami ada seorang peserta yang ingin bertanya kepada Puan. Hai Melissa, boleh share berapa umur pesakit yang paling muda buat rawatan radioterapi daripada Faizah HP?
Okay.
Oh, ada subsequent soalan juga daripada Encik Faizah. Dia tanya, mengikut pengalaman, dapatkah pesakit kanak-kanak menghabiskan rawatan radioterapi mereka?
Okay. Actually, ada yang paling muda. I think umur 3 tahun. 3 tahun, but tapi saya tidak ingat case apa, but I think it was head and neck, maybe a brain case. 3 tahun paling muda. And then mengikut pengalaman, dapatkah pesakit kanak-kanak? Kalau kanak-kanak tu under GA, okay saja. But then tapi then kita kena tengok dia punya blood count semua kan. So sometimes they will withhold from the treatment. And then for bigger children, soalnya diorang boleh habis rawatan sebab there's no so much of side effects. There's not so much of side effects for them. We also have one CSI cases. Sekarang ada satu kami treat case CSI. So patient sudah habis week 4 and he is still okay lah. FBC blood count semua pun still okay lagi. So I think as long as there is encouragement, the kids can finish their radiotherapy treatment.
Okey, terima kasih Puan Melissa. Satu lagi, dia juga ingin bertanya, pernahkah kanak-kanak buat simulasi dan rawatan tanpa GA? Biasanya, kes apa dan umur berapa?
Buat simulasi dan rawatan tanpa GA pernah umur 5 tahun. I think 5 tahun, 6 tahun ke atas. Tapi ada juga yang without GA, I think budak tu umur 10, 11, 12, something like that. Dia buat SIM without GA, without sedation lah. Then I think this case is a brain case. Tapi patient ni setiap hari perlu kena pujuk untuk buat rawatan radioterapi. So dia punya bapa kena selalu bagi something supaya dia buat rawatan radioterapi. And then it depends on the kids lah. Some kids they are very obedient. I think it's up to the upbringing kalau dorang jenis yang dengar cakap atau tidak, something like that lah.
Okey, terima kasih Puan Melissa. Diharap dapat menjawab soalan Encik Faiza ya. Dan Puan Melissa, kami ada seorang peserta dari Encik Zainiza Azmi. How did you manage mucositis in pediatric case?
Okay, so for our part in radiotherapy, we do a weekly review to check the oral hygiene of the patient or if there is any mucositis lah. But I've read that mucositis can also be caused by chemo. So they gave patient amifostid, if I'm not wrong. Tapi untuk dari segi radioterapi, kita akan buat weekly review. And then we also advise patient to do good oral hygiene, macam gargle and all that on the first day of treatment. That is our mandatory patient care lah.
Okey, terima kasih Puan Melissa. Kami ada beberapa soalan lagi, boleh bacakan ke? Ada soalan seterusnya iaitu, what is the age of small children that can do radiotherapy?
I think what is the age of small children that can do radiotherapy? I think starting from the age of, I'm not very sure, but we have a 3-year-old patient doing radiotherapy. So yeah. I think
Okey.
from yeah.
Boleh.
I think from all ages, but it depends on the pediatrician. Diorang punya pakar pediatrik, macam mana dia punya management lah. Because I think they don't just give you radiotherapy, because radiotherapy has a high lead toxicities kan. So something like that lah.
Okey. Puan, terima kasih diucapkan Puan Melissa. Sebenarnya kami ada beberapa soalan daripada peserta, tapi disebabkan kekangan masa, kami terpaksa teruskan dengan penceramah yang kedua ya. Nanti soalan daripada Puan Mahayu ataupun Encik Roslan kami akan jawab pada sesi Q&A ataupun lepas penceramah Puan Nur Fatihah. Boleh ya Puan Melissa?
Okay, thank you.
Ya, ribuan terima kasih diucapkan kepada Puan Melissa di atas sesi soal jawab dan juga ceramah sebentar tadi. Okey, untuk acara seterusnya, majlis ingin menjemput panel jemputan kita yang kedua iaitu Puan Wan Nur Fatihah binti Wan Asmi. Beliau merupakan seorang juru X-ray radioterapi yang bertugas di Hospital Kuala Lumpur. Beliau memperolehi ijazah dalam Bachelor in Medical Imaging and Radiotherapy pada tahun 2012. Beliau juga mempunyai banyak pengalaman di sektor swasta dan kini di kerajaan sepanjang perkhidmatan beliau. Tanpa melengahkan masa, majlis dengan segala hormatnya mempersilakan Puan Wan Nur Fatihah untuk menyampaikan ceramah beliau. Dengan segala hormatnya, dipersilakan. Okay, majlis mempersilakan Puan Wan Nur Fatihah untuk memberikan ceramah beliau ya. Okay, kami tunggu Puan Wan Nur Fatihah untuk masuk sekejap sebab ada sedikit masalah teknikal. Diharap semua para peserta dapat bersabar ya. Bolehlah minum-minum dulu, makan-makan dulu. Sementara menunggu penceramah kita untuk masuk ya. Semua dah breakfast ke hari ni?
Okay, sorry. Ingat tak? No?
Dapat dengar?
Tak dengar? Kek, dapat dengar tak Kek?
Dapat dengar Puan? Boleh
Okay,
start?
baik. Okay, Assalamualaikum and good morning to everyone. First of all, I would like to say thank you for spare your time today to hear my CME today. Okay, today I would like to share my hospital experience, which is in HKL, on how we treat head and neck cancer by using helical tomography. Okay, I choose this topic because in our department, we this modality is the latest one modality that we have. Okay, so this is my topic today, helical thermotherapy in head and neck cancer. Okay, before we go more details in my topics today, this is my outline. Okay, I will share a little bit of cancer statistics in our country and introduction of what head and neck cancer, what causes of cancer, the treatment pillar itself, and what is a helical thermotherapy, and what the treatment procedure. In the treatment procedure in head and neck cancer, I choose NPT case. And the treatment side effect from thermohelical. And conclusion also I have one case study and reference. Okay. Cancer statistic in Malaysia in 2020, there is 48,639 new cases were reported in our country. And this one is predicted to be double in 2040. And 1 in 10 people in Malaysia actually will diagnose with cancer in their lifetime. So this is a top 5 most common cancer in Malaysia. Number 1, we have breast cancer. Number 2, colorectal cancer. Number 3 is lung cancer. And number 4 is head and neck cancer itself, which is nasopharyngeal cancer. And number 5 is liver cancer. And for the worldwide, estimated 562,328 people were diagnosed with head and neck cancer in 2020. Okay, this is a pie chart. So here we can see that nasopharyngeal cancer is around 4.6%. The percentage in both sex and all ages in Malaysia. Okay, now we go to what is head and neck cancer. Actually, I think this slide also was shared by Melissa before this. Okay, what is head and neck cancer? Head and neck cancer actually is a different malignant tumors that develop in around the throat, larynx, nose, sinus, and also our mouth. Okay, most head and neck cancer actually are squamous cell carcinoma. So this is anatomy for head and neck. Okay, actually there's a lot of causes that lead to cancer, head and neck. Okay, number 1, we have alcohol and tobacco use. Okay, alcohol and tobacco use actually is the people use alcohol, and both alcohol and tobacco is more risk to get the head and neck cancer compared to people who use either alcohol or tobacco only. Okay, number 2, we have pen. I think pen, like in Malaysia, Malay we call as Siri. Siri or Penang. Siri or Penang, right? Okay, and number 3, we have Epstein-Barr virus. Okay, people work in occupational exposure also has a high risk to get the head and neck cancer. And we have also radiation exposure. And other than that, we have genetic disorder. Okay, here. Okay, what the treatment pillar used to treat the head and neck cancer? 1, we have surgery. Actually, treatment pillar that used to treat the head and neck cancer is depend on many factors, such as the location of the tumor, the staging of the tumor. So these are the treatment pillars the doctor will plan depends on that factor. Either the patients go surgery, chemotherapy, immunotherapy, and also radiation therapy, of course. So in radiation therapy, we have two, we can divide into two. We have internal radiation therapy and external beam radiotherapy. So in today, I will highlight in external beam radiotherapy. Okay, in radiotherapy or called as EBRT, we have photon therapy, including 3D CRT, intensity modulated radiotherapy, and helical tomography. Also, we have image guided radiation therapy. So today, we'll focus on the helical tomography. Okay, other than that, we have also electron beam radiation therapy that most often used to treat on superficial skin near the body surface. Okay, now we go to what is helical tomography. Okay, helical tomography is a form of MRT that can deliver radiation in a spatial way. The radiation machines deliver many small beams of radiation at the tumor from different angles around the body. And it may allow for radiation to be even more precisely focused. It can target, the dose given the dose given to the target is more confirmed. Yeah. And this one is the patients lay on a table and it's moved through a donut-shaped machine. And the radiation source in the machine rotates around the patient's body in a spiral pattern. Okay, in our department, this is our tomography machines. This is the latest modality that we have. Okay. Okay, our brand for this tomography is Accurate RadiZ system. Actually, this machine only use mega voltage energy for both imaging and also for treatment. We don't have kV energy. So this machine installed in HKL on October 2021, and the first case was treated on December 2021. Okay, so far the total head and neck cases that was treated from December 2021 till now is 48 cases for head and neck cases only. And this one 199 cases including all other cancers like CA breast, CSI, and also TBI. Okay, I will share a little bit of treatment planning. Okay, this is treatment planning. The software we are using in treatment planning is Precision. Okay, so from here we can see that tomohelical, the dose given here is more confirmed. We can kita boleh minimize the dose at organ at risk. Okay, so here we can see that the orange one is the PTV. You can see that here 70 gray dose received here. Okay, Now we go to treatment procedure in treatment procedure that we do in thermohelical radiotherapy. Okay. Okay, this is positioning aids and accessories we use for MPC patients. I think all the accessories here we all already know. This is the overlay Silverman. We have also Silverman headrest and U-shim. This one is S-type thermoplastic mask. Because helical thermotherapy is one of the IMRT technique. So we normally use S-type BDS for head and neck cancer. Okay, this one is a shoulder retractor to pull down the patient's shoulder. Okay, how we do the treatment? Okay, first we set up all the accessory needs during stimulations procedure, and ask patient to lay down on the treatment couch. After that, we draw the landmark or baseline on patient's head. Okay, after got the landmark, we move longitudinal couch to match the black pin on overlay with the lateral laser itself, and try to adjust patient's head to align with baseline with the laser. Okay, I will show the picture here. Okay, this is how we first we draw the baseline on patient's body. The landmark based on the sequencing procedure. Okay, after align with the laser, we put on the S-type BDS on patient head, and move couch to set the origin with the laser for both for both side right and left. Right. Okay, here is the documentation we use. This is treatment sheet. So here we can see that the prescription dose the doctor given for this patient is 70 gray in 35 fractions in 7 weeks. This is a dose for MPC cases. Good. So this is a landmark, patient landmark. Okay, this one is a translation shift sheet that we use in thermohelical. We noted all the reading that we get during position patients. Okay, after we set up patients, everything is okay, and then we go for imaging verifications. So just I said before, we use we use MVCT for imaging verification. So here you can see that the we select the area scan. Normally we try to cover all the PTV. So that it don't miss the PTV area. Okay, here you can see that the blue one is already scanned area, and the yellow one is will be scanned. Okay. Okay. The scanning time is around. You can see here is around 129 seconds. Okay. Okay. This is a scan time. Estimate 3 to 5 minutes for this patient. This is the automatic, and then we go for automatic registration. Actually, automatic registration is done by the system software itself. Okay, then we corrected manually and try to get the shift below 3 mm for all direction lah, lateral, longitudinal, and also the vertical. Okay, for the first day of treatment, we go for online review. And the ability, we do daily ability for all cases, not only for hidden cases, but other cases also we do daily MVCT. Okay, the beam on time is around 7 to 10 minutes to complete the treatments. Okay, here I have video to show on how we do the imaging verification. Sorry, this video can't play. Actually, this I will show the video how we do the image verification, but I don't know how, why I can't play here. Just leave it. Sorry for that. Okay, it's okay. Okay, this is the appearance for the treatment. After we do the verification, we do the treatment. So here we can see that the fractionation of the treatment. For this day, patient is 9 fractions. Okay, and then the treatment time is around 464 seconds to complete for the treatment. Never mind. Okay, what the treatment side effect in head and neck cancer? Okay, normally patients we get skin redness, skin irritation, headache, difficulty in swallowing, change in taste, loss of appetite, lost weight, alopecia, mouth ulceration, and also feel stiffness on their jaw. Okay, this is a picture of side effect. But I think this one is the patient is oropharynx cancer. You can see that the neck tend to burn, like burns. Okay. Okay, it's fine also. Just I said before, the patient we lost their hair at the back only, here only. Okay. Okay, this is my conclusions. Actually, helical thermotherapy is particularly promising for the treatment of head and neck cancer, because its sharp dose gradient maximally spare the many radiosensitive organs at risk nearby. Okay, by using helical thermotherapy techniques in combination with a relatively small field and the binary MSR, optimal sparing of healthy tissue can be reached. And with a daily MVCT scan is made prior to each session to compare the position of the target volumes and the organ at risk with their position on the plenary reference CT scan. Okay, this is my case study. Okay, this case study is NPC patients. There's a 47 years old Chinese man, previously known in medical illness. This patient also is a chronic active smoker for more than 30 years and also alcoholic drinker, but he stopped 2 years ago. Firstly, this patient presented with painless right neck swelling since June 2021. And this neck swelling slowly increasing in size. And this patient also has on-off epistaxis, nose bleeding. Okay, and how this patient diagnosed with MPC? Okay, firstly, patient come to see doctor and doctor make a palpable on neck swelling. That swelling is measuring about 6 times 6 cm. Firms and not tender. Nasal endoscopy also was done to this patient. Then the result show tissue irregularity over right fossa of Rosenmuller. Fine needle aspiration also was done at the neck swelling, and the result was consistent with metastatic carcinoma. CT tap was done on 10 January 2020 for staging purpose and enhancing lesions since mainly at right fossa of Rosenmuller. PET scan was done on 28 January 2020, and the scan evidence show the FDG avid primary malignancy of right fossa Rosenmuller with cervical node metastasis. Okay, after see the doctor, and then doctor plan to give this patient new adjuvant chemo and radiotherapy for the patient cervical, and with the dose 70 gray in 35 fractions with CTRT. And the patient was the CT simulation for this patient was done on 21st April on 2020 and start to treatment at Tomo Helica on 8 June 2020 and was complete successful complete the treatment on 27 July 2020. Okay, this is a treatment sheet recommendation for these patients. Okay, this is a plan treatment plan for this patient. You can see that the PTV area cover at the fossa of Rosenmuller here. This one is a high dose repeat at the PTV area. Okay, the treatment time for this patient is around 460 seconds. If I'm not mistaken, is about 5 to 6 minutes to complete the treatment. Okay. Okay, what happened to this patient during the treatment? Okay, for the first week of treatment, the side effect not so obvious. But when patient go for second week of treatment in 14 fractions, it currently show the grade 1 skin reaction on neck, but patients still don't have mucositis. When patient go to third week of treatment, currently the patient weight is lost about 3%. So what we do, we send to doctor to review and then refer dietitian, and the dietitian advise this patient to take the ensure. And patient took once a day only. Okay. When go to fourth week of treatment, the patient start complain of dysphagia, loss of appetite, but still can tolerate to soft diet. At this we also patient had grade 2 skin reaction and grade 1 mucositis. Okay, on the fifth week of treatment, the skin reaction still in grade 2 and mucositis also still in grade 1. This patient still continue meat supplement. In 6 weeks of treatment, patient still taking soft diet only like porridge because he cannot swallow. So that's why the dietitian ask patient to take soft diet. And the skin reaction in grade 1 and mucositis is already in grade 2 with oral candidiasis. There's a lot of ulcer in his mouth. Okay. On the last day of treatment, this patient lost 8% weight from first day of treatment. And grade 2 or 3 oral ulcer, grade 1 xerostomia, and halos and no palpable. Okay, this patient after complete the treatment, he has TPA 3 weeks after treatment at Onco Clinic to follow up. But when I go through to his case note, I think this patient not coming for review the patient. Maybe he goes appointment at ENT HRPD. Okay, so this is obvious side effect for this patient. We can see that at the back of head, the patient's hair so much lost so much hair here lah. And the skin also look like crack. Okay. So this is my reference. And I think that's all from me. Thank you.
Okey, terima kasih diucapkan kepada Puan Fatin. Jikalau peserta ada sebarang soalan, saya tanya yang first dulu Okay, daripada Farah Najwa untuk Puan Fatin, how many patient do you treat per day and how many minute each patient?
Okay, how many patients we treat per day? Okay, so far we have 25 patients a day. That one include all the cases, not only for head and neck. Because in our department we also treat TBI in chemotherapy. Another one question, what patient is?
And how many minutes for each patient?
Okay, minute for each patient it depend on patient case. Like I just say before, head and neck it normally take around 7 to 10 minutes to complete for one session. That time only for beam on time only, not include patient positioning, patient setup or MVCT. Okay, Farah Najwa, as I answer your question.
Okay, terima kasih Puan Fatin. Ada lagi ya Puan Fatin?
Okay, boleh.
Tak menjawab boleh tanya penceramah balik ya, jangan malu-malu. Okay, Puan Fatin, saya move on kepada second question, boleh?
Boleh.
Okay, daripada Miss Karen Howe. Hi Miss Fatin, may I ask what would radiation therapists advise patient on the education for skincare ya?
For skincare?
Ya.
Okay, normally kita akan hantar, kalau kita dah nampak like side effect dekat patient punya skin, kita akan hantar patient untuk review doktor first. And then untuk patient care tu kita selalu cakap dekat patient don't apply any soap or oil, lotions during the treatment duration lah. But after patient review doktor, biasanya doktor akan prescribe hydrocortisone cream to patients. But this patient dia kena apply aqueous cream tu after we treat, after we do radiotherapy.
Okay. Ada. Okey ke Miss Karen? Adakah penceramah menjawab soalan ataupun ada soalan lain yang ingin ditanyakan, diajukan kepada penceramah? Okey, Puan Fatin, saya move on ya. Sudah.
Boleh.
Terima kasih Puan Fatin dan juga Miss Karen. Okay, next question. Untuk for skin and when do the patient need rest?
Saya tak nampak question tu.
Boleh Puan?
Sorry sekejap saya
Bacakan balik soalannya.
boleh.
Boleh. Saya bacakan balik soalannya. Okey, daripada Encik Roslan. For skin reaction management, what is the standard practice? Soalan satu. Yang kedua tu, when do we start give cream and when do the patient need rest?
Okay, when we start the cream. Okay, biasanya cream tu sebab kita tengok kalau macam untuk minggu pertama biasanya side effect skin reaction tu tak berapa nak nampak sangat. Tapi bila patient dah masuk second week, skin reaction kita dah mula nampak macam like skin start to red, and third week like skin peeling. So we send patient to review with doctor, and normally doctor will prescribe the aqueous cream tu like bila patient dia skin reaction tu dah start macam nak merah-merah. Okay. So another one question is
when do the patient need rest?
okay. Sebab macam dekat tempat saya ada satu patient dia punya treatment tu memang ada menggunakan bolus lah. Kita tak guna bolus tapi kita guna wet gauze untuk build up dia punya dose tu. Bila guna bolus tu dia punya skin reaction tu memang sangat worse lah. Memang nampak macam skin peeling, lepas tu macam dia macam wet. So kita panggil doktor untuk tengok dulu sebelum kita proceed treatment, and then masa doktor datang tu dia tengok, so memang masa tu doktor minta patient to rest, not for RT lah, selama I think masa saya dalam 3-4 hari macam tu lah untuk dia rest dulu.
Okay, Puan Fatin, ada soalan daripada saya juga. Puan Fatin boleh jawab ke yang soalan seterusnya?
Banyak ni soalan ni.
Banyak soalan sekejap ya. Daripada Encik Asif pun sudah Hello? Puan Fatin?
Okey, ada.
Ada
Ada.
Okey. Kalau saya bagi laluan kepada Puan Melissa dulu untuk jawab soalan, nanti baru kami balik ke Puan Fatin boleh?
Boleh.
Boleh? Okey. Kejap Soalan untuk Puan Melissa. Puan Melissa sudah bersedia ke?
Okay.
Ya, Puan. Untuk soalan tadi, untuk Puan Melissa, dari Puan Rumaiza, dari segi side effect, adakah PITS alami skin reaction yang lebih teruk jika dibandingkan dengan adult?
Okay, kalau dibandingkan dengan adult, skin reaction untuk PITS is kurang sikit dari adult lah. So before this, I think 4 years back, kami ada head and neck patient, semuanya pediatric, umur around 10, 12, 13 macam tu. So I think I remember 3 patients, and then they all do head and neck treatment, and sampai ke penghujung rawatan pun they are still active and their skin reaction is not that bad. Yeah, so that is for skin reaction.
Okey,
Okay.
terima kasih. Puan Melissa, boleh saya move on kepada second question?
Boleh?
Okey, sorry saya terpaksa tutup video sekejap sebab line sedikit unstable. Untuk soalan kedua dari Mahayu Ismail, SWACH masih meneruskan art kreatif pada PITS BDS sehingga sekarang? Itu soalan dia.
Yeah, we still do art creative to our PITS BDS, tapi range umur tu kita sudah kasih kurang. So before this, we do to all pediatric cases. So now we only do for 5 years and below. Sebab kita punya artis sekarang ada komitmen belajar, so susah sikit untuk buat untuk semua PITS cases lah. But we still do. Okay. And then I think the next question is from Mr. Roslan. Pesakit yang perlu sedation adakah akan menyebabkan peningkatan berat badan sepanjang rawatan? So we see cases. Actually, I don't think the sedation is giving them weight gain. I think it's the drugs that they use. So kebanyakan yang ada weight gain ni adalah pada patient yang ada buat treatment to the brain. I think it's because of the dexamethasone. So dexa is used to reduce the inflammation of the brain lah because of treatment. Then pada masa yang sama dia akan menyebabkan weight gain juga. So when we notice weight gain, we will inform the doctors. So they will either taper off or reduce the dexa dose to the patient lah. Okay, I think that answer your questions.
Okey ke? Adakah menjawab kepada soalan para peserta? Ada sebarang soalan untuk Puan Melissa lagi? Minta maaf ya, line saya sedikit unstable. Puan Melissa ada apa-apa nak bagi last word ke? Untuk sebagai conclusion?
Okay, sebagai conclusion, untuk case pediatric, it's just that I hope we can upgrade our facilities lah. Because, yeah. And then I think our communication with other discipline is getting better. But only the facility, if we can upgrade it, it will be really good lah. And that is all from me. Thank you.
Okey, terima kasih Puan Melissa. Sekejap ya. Okey, untuk para peserta, saya ingin maklumkan bahawa link untuk feedback form ada di chat box. So, para peserta boleh isilah link feedback form itu untuk mendapatkan sijil. Semua orang dapat ke feedback form tu? Link feedback form ada ke?
Ada.
Ada sebarang soalan lagi untuk penceramah kita? Untuk yang bertanya tadi, boleh tanya terus dengan Puan Fatin ya, jikalau nak. Minta maaf banyak-banyak. Okay, terima kasih diucapkan kepada Puan Melissa di atas sesi soal jawab tadi. Untuk sesi soal jawab dengan Puan Fatin, ada sesiapa ke? Ada untuk para peserta yang mahu bertanya soalan?
Okay. Dekat sini pun saya, dekat chatbot ni pun saya ada baca beberapa soalan lah.
Aha,
Okay.
boleh Puan?
Daripada
Puan Fatin, nak saya bacakan soalan?
saya cari. Okay, ni daripada Shiful. Do you do daily MVCT or weekly only? Okay, dekat kita orang punya department untuk MVCT memang kita akan buat daily lah untuk semua kes. Tak kisahlah kes tu bukan head and neck cancer ke, macam like CA breast, pelvis, memang kita akan buat daily MVCT. Setakat ni pun yang plan yang ada dekat our department, banyak yang plan yang menggunakan helical tomoterapi lah. Untuk direct tomoterapi kita just kalau tak silap saya baru 2 kes sahaja. Tu pun dah complete treatment lah. Memang kita buat daily MVCT. Okey, ni soalan daripada Puan Mahayu. What was the resimulation rate among the 88 head and neck cancer patients compared to LINAC and IMRT? Resim rate among the 88 head and neck. 88. Okay, kalau rate untuk resim, kalau dekat tomo, setakat ni kebanyakan yang kita resim case adalah case head and neck cancer lah. Sebab salah satunya bila kita go for MVCT, kita nampak macam perubahan dekat PTV tu macam ada yang makin mengecil. Sometimes ada juga patient yang dia punya tumor tu macam tak ada apa-apa progress. So bila patient start macam dah kurang makan, loss of appetite, dia dah mula start berat badan menurun, and toe pain dah mula longgar, kita panggil doktor, and doktor tengok dia punya MVCT. Kalau tak okey, doktor minta jugalah untuk buat resim balik. Tapi dia punya rate tu tak adalah kerap sangat untuk sim case head and neck. Ada tu memang ada, tapi tak banyak lah.
Hai Puan Fatin, Assalamualaikum.
Waalaikumsalam, Puan Azmah. Okay.
What is your main problem during treatment, radiotherapy treatment in traumatherapy, especially in RT-HKL? Thank you.
Okay. Thank you, Puan Azmah. Okay, main problem when we treat head and neck cancer, it's actually we try to match the vertical part. Sekejap ya, I show the sekejap. I show this picture. Okay. Selalunya kalau head and neck ni masalah yang kita orang hadapi lah kebanyakannya kes head and neck cancer ni nak matching dekat dekat area neck. Dekat area neck ni macam bila dah masuk minggu yang minggu pertama tu okey lagi, minggu kedua, minggu ketiga and so on. Dia dah start macam tak boleh nak match tau, macam susah tolerance dekat neck area ni memang agak susah nak dapat. Tapi kita cubalah kalau macam once kita buat MVCT kali pertama tak okey, kita try juga, pernah sampai 3 kali jugalah kita orang reset up patient and do the again MVCT. Kalau macam tak dapat juga, kita call doktor direct to ask doktor to see lah, to online review, minta pendapat doktor. And then satu lagi problem untuk head and neck cancer ni, kebanyakannya pesakit dia akan complain sakit dekat bahagian belakang ni. I don't know why, because maybe because the treatment time of tomo lah. Sebab untuk tomo ni dia punya masa lebih kurang dalam 7 ke 10 minit untuk patient tu baring dekat on treatment couch tu. So some patients bila dah habis jerawatan, they start complain, cakap macam belakang ni sakit lah. Okay ke Puan Azma?
Okay, thank you Puan Fatin.
Okey, terima kasih Puan Fatin. Ada lagi daripada para peserta?
Okay, ada lagi satu soalan. Biasanya untuk tomoterapi di RT-HKL sampai pukul berapa ya rawatan? Sama ada sampai pukul 7 malam ke 8 malam ke? Just nak tanya lah.
Boleh. Okay, sebenarnya dia punya sebab dia bergantung dekat jumlah kes yang masuk lah sebenarnya. Kalau setakat ni, sebab macam dekat HKL, dekat tomoterapi ni kita dah mula start treat kes-kes TBI. Kita ada TBI, kita ada TSI. So once ada kes-kes TBI dan CSI masuk serentak, memang itu mengambil masa yang lama lah untuk kita habiskan satu-satu treatment tu. Pernah kita treat sampai pukul 7 lebih. Baru habis kes untuk semua kes lah, sebab yang tu masa tu ada TBI dan juga ada kes CSI sekali. Kalau macam tak ada TBI, mungkin dalam pukul 5-6 macam tu dah boleh settle lah kes. Sebab kita tahu kan tomoterapi ni kan dia punya treatment time dia memang sangat lama. Sebab contoh satu kes tu CA breast pun memang ambil masa yang agak lama untuk habiskan satu rawatan, satu fraction tu. Lebih kurang dalam 1000 second untuk treat patient tu sahaja. So kalau ada lagi macam TBI, CSI, memang lagi lama lah.
Okey, terima kasih Puan Fatin.
Okay.
Puan Fatin ada satu soalan juga yang para peserta ingin bertanya. What were the things that radiation therapists need to evaluate CBCT for head and neck as your case study?
What do you think? Sorry, tak.
Bolehkah Puan Fatin? Kalau tak, saya baca sekali lagi.
Boleh sekali.
What were the things that radiation therapists need to evaluate CBCT for head and neck as your case study? Daripada Muhammad Khairul Zamri. What will be the things that radiation therapists need to evaluate CBCT for head and neck?
Okay, what will be the things that RTT need to evaluate CBCT for head and neck as your case study? Okay, siapa tadi? Ini soalan daripada Encik Khairul kan? Okay,
yes.
Cik Khairul ni maksudnya dia fokus untuk tomo lah Okay, kalau untuk tomo kita tak evaluate CBCT lah, kita evaluate MVCT. Okay, normally kalau dekat head and neck, kita tengok dekat dia punya bone matching lah, bone matching, and then the PTV area normally at the fossa of Rosenmuller tu, memang itu kita cuba untuk dapatkan field matching, image yang hari ni dengan yang masa CT SIM punya.
Okey, Encik Muhammad Khairul, adakah you menjawab soalan
Normally
ni,
memang
Encik?
kita
Terima kasih, Puan Fatih.
kita akan fokus dekat yang PTV area lah, PTV area.
Okey, ada soalan daripada Encik Muhammad Zirwan. Dia ada angkat tangan.
Okey, Assalamualaikum. Dengar ke tak?
Salam, dengar Zek.
Boleh
Assalamualaikum.
dengar, Encik?
Okey, pertama sekali tahniah Puan Marissa dan Puan Fatih dan atas perkongsian. Puan Fatih, saya ada satu soalan lah nak tanya. Kan kita untuk tomoterapi ni, kita akan buat MVCT kan?
Betul?
Lepas tu untuk kes CSI dan TBI, sebab dia one shot kan daripada hujung kepala sampai hujung kaki.
Okay.
So which part yang kita concernkan untuk matching image tu?
Okay.
Untuk CSI dan satu lagi TBI lah. Okey, itulah soalan saya. Terima kasih.
Okey, terima kasih Cik Zirwan, Cik Zirwan. Okey, macam ni. Kalau untuk TBI dan TSI, sebab kalau untuk tomoterapi ni dia ada limitation untuk dia longitudinal table. Kalau tak silap saya dekat kita orang punya Radiotherapy ni dia 135 cm saja dia boleh go in lah. So kalau macam TBI kita tahu dia treat satu badan kan, total body. Biasanya dekat sini, dekat tempat kita orang, kita akan divide by 2 plan lah, upper body and the lower body. So untuk upper body kita akan take first, and then after dah siap untuk upper body tu kita akan turn patient di position balik untuk feet first pula. So kita kalau untuk evaluation MVCT tu untuk apa tu kita takkan dapat sebab kita pilih scan area, kita tak akan ambil daripada kepala sampai kaki lah. Untuk hari pertama memang kita orang akan cover daripada head sampai junction. Sebab kita ada dua plan kan, upper dengan lower. So memang kita akan ada junction lah. Memang kita akan evaluate satu-satu untuk MVCT. Lepas kita dah buat upper body, dah siap treat semua, dah buat MVCT, kita teruskan ke untuk lower body pula. So dekat lower body tu kita ambil daripada junction sampai ke ujung kaki dia lah. Itu untuk hari pertama. Biasanya hari pertama memang kita orang akan cover semua. Tapi bila dah masuk fraction kedua dan ketiga, kita cuba kecilkan dia punya scan area lah. Untuk CSI pun sama juga. Semuanya CSI ni sebab kebanyakan pesakit CSI ni adalah kanak-kanak. So biasanya kita akan buat one shot plan je. Kita memang tak ada buat macam apa lower, tak ada macam TBI lah. So scan area dia punya scan untuk MVCT tu memang daripada kepala sampai dia punya yang ujung tu lah, yang koksit. Kita try to cover the area.
Assalamualaikum, Cik Fatih.
Salam.
Okay, saya ada satu soalan. Actually saya mungkin tadi dah send, mungkin termiss, lost ke. Okay, so nak tanya kalau patient lose weight, gain weight, macam mana kita monitoring system dekat HKL. Maksud saya for adaptive radiotherapy. So how we detect that the patient requires for adaptive planning and then when we decide.
Okay, untuk monitor patient punya weight tu memang kita ada satu form lah. Untuk head and neck memang kita ada attach satu form. Untuk setiap minggu kita akan, bila patient datang je sebelum lie down on the treatment couch tu, kita akan ambil dulu patient punya berat badan, and from week to week tu kita dah boleh nampak lah berapa banyak dia lost weight semua. Kalau macam banyak sangat memang kita akan bagi tahu doktor, and then doktor tengoklah macam mana plan, sama ada dia nak resim ke ataupun proceed ataupun buat yang adaptive radiotherapy tu. Sebab adaptive radiotherapy ni pun sebenarnya saya baru tahu juga, sebab macam last week ada kes yang dia ada macam like neck swelling yang memang agak besar dekat dia punya ni neck ni. Bila kita MVCT, kita tengok PTV yang doktor draw tu dia punya tu macam melebihi daripada outlines yang doktor draw. So memang kita nampak dia punya swelling tu makin membesar, bukannya dah shrink kan, memang makin besar. So panggil doktor datang, dia tanya boleh buat adaptive radiotherapy tak? Saya macam yang tu kita kena tanya physicist. And then doktor panggil physicist, dia orang macam try lah untuk buat adaptive, maksudnya untuk tengok change balik dose ke macam mana. Doktor pun sebenarnya masa untuk patient ni pun doktor sebenarnya plan untuk resim, tapi bila hari yang keesokannya bila kita panggil untuk buat treatment, rupanya doktor dah onkan DEXA dulu untuk pesakit ni. So bila dah buat MVCT, kita nampak dia punya neck swelling tu mengecil balik. So doktor decide no need to do resim lah for today, proceed treatment. Proceed je macam biasa.
Okay, thank you for answer. Meaning that belum ada adaptive planning punya.
Belum ada lagi lah setakat ni, memang dekat sini tak ada lagi adaptive.
Okay. Terima kasih.
Sama.
Okey, makasih Puan Fatin. Okey Puan, ada lagi soalan? Boleh ke Puan saya bacakan soalan?
Boleh.
Boleh. Okey, daripada Encik Muhammad Khairul juga. What were the action level for head and neck case?
What? Saya tak, what will be the action? What will be the action level for the next case? Okay, action level tu maksudnya macam mana Encik Khairul? Boleh tak Encik Khairul on mic?
Encik Khairul?
Okay, sorry.
Tak apa.
Action level tu maksudnya movement of the head and neck area lah. For example, like inside the QAP kan, they inform us about 3 mm kan. So what we need to know, so kita nak tahu apa yang action level from your side ni for chemotherapy lah.
Okay, untuk
So what will you do lah actually?
Okay, untuk yang ni sebab macam kita tahulah macam head and neck dekat tomo pun kita still use the tolerance change below the 3 mm. So we try to get this shift lah. Kalau macam kita tengok, kita try matching dulu dekat dia punya bone matching. Kita tengok dulu kalau macam banyak sangat susah sangat dia nak matching, mungkin ada error daripada setup positioning lah. So we try to reset up patient and then do the MVCT sekali lagi lah. Kita try untuk dapatkan, tapi setakat ni lah jarang lah yang kita dapat melebihi toleransi dia tu melebihi 3 mm. Ada tapi tak banyak lah. So dekat sini memang kita cuba toleransi dia tu memang 3 lah kalau untuk tomo helical. Sama juga macam kes IMRT yang dekat linek lain pun sama juga.
So berapa kali biasanya untuk BCT?
Okay, biasanya setakat ni ada pernah sampai 3 kali lah kita orang buat MVCT. Scan bila pertama kali buat tu tak okey, kita cuba lagi kali kedua, pun nampak macam tak okey, kita buat lagi kali ketiga, tapi bila dah masuk kali kedua dengan kali ketiga tu kita orang cuba kecilkan dia punya range untuk sebab dekat macam tomo helical ni dia ada acquisition pitch dia tau. Kita boleh pilih slice thickness untuk scan. Kalau macam kita pilih slice thickness 2 mm, dia punya scan time memang lagi lama lah, tapi image dia memang terbaik lah, image dia 2 mm. Tapi biasanya kalau dah masuk yang reset up kali ketiga tu, kita orang cuba ambil yang cost 3 mm lah untuk kurangkan masa scan tu. Dan kurangkan dosa dekat patient sebab scan banyak kali kan.
Okay, terima kasih.
Okay,
Terima kasih Puan Fatin. Puan Fatin boleh ke?
boleh.
Tu soalan lagi?
Ada lagi Banyak.
Ada lagi? Okey. For head and neck case, patient got weight loss during TX period. Berapa lama masa yang diambil untuk new scan and planning?
Okay, untuk new scan dan planning. Kalau patient kena resim, biasanya sebab macam dekat HKN ni kita ada hari-hari doktor tau, hari-hari kes untuk doktor. Hari-hari kes untuk doktor pakar lah, kita tengok kalau macam kes doktor tu katakan minggu depan, katakan kita buat hari ni tapi tiba-tiba doktor nak decide nak receive patient ni. So mungkin dia akan tengoklah minggu depan punya slot ada tak kekosongan tu, sebab kita memang tahu kan memang sangat ramai pesakit lah. So dia cubalah kalau ada kekosongan tu dia akan masukkan hari dia lah, maksudnya harian dia tu. So bila dah patient dah SIM, plan nak siap tu bergantung dekat pakar sebenarnya, doktor pakar. Sebab kadang-kadang ada juga yang macam bila nak resim, doktor minta kita orang treat dulu dengan guna plan yang sedia ada. Sampailah plan tu dah ready, yang baru, plan yang siap tu, baru treat guna plan yang baru. Ada mengambil masa lebih kurang dalam minggu jugalah. Pernah ada juga dekat Tomo. Seminggu juga baru dapat new plan. And proceed with the new plan lah. Before tu kita memang guna plan yang lama dulu. Okay ke Cik Taufik?
Cik Taufik, adakah soalan Cik dijawab? Ada sebarang soalan lagi ke daripada para peserta?
Sorry, nak tanya. Regarding the tomotherapy kan, you guys using a MVCT kan?
Betul.
Okay, so like for example, if you do like normally it's like KVCT is a low dose radiation compared to MVCT. As you mentioned, it's 3 times of doing CVCT. So is that any like for example, you deduct the MU from the planning from the treatments, or you just just keep it as it is?
Okay, that one so far we just keep it that plan lah. Maksudnya tak ada buat reduction dekat MU calculation tu, tak ada. Memang kita proceed dengan plan yang ada je. Sebab kalau tak silap saya untuk acquisition pitch untuk Tomo helical ni, dia untuk every slice thickness tu dia ada dia punya berapa gray yang patient akan dapat untuk setiap every 7 slices yang kita pilih. Saya rasa kalau macam kita pilih yang 2 mm slice thickness, memang dia punya scan area tu memang banyak dan patient akan dapat terima dos yang lagi tinggi lah. Tapi setakat ni dekat sini, macam yang saya cakap tadi, walaupun kita repeat every 3 kali ke, memang kita tak ada buat yang reduction dose, MU calculation balik tu tak ada.
Okay, thank you.
Terima kasih.
Okey. Terima kasih Puan Fatin dan juga para peserta di atas sesi Q&A ini. Okey, sampai sinilah sesi kita untuk hari ini ya. Okey, sebelum tu saya minta semua para peserta untuk mengisi link feedback form yang telah pun ada di chat box untuk mendapatkan sijil. Sila isi dengan lengkap ya. Okey, sebelum saya tamatkan sesi seminar kita, dimohon setiap peserta khusus untuk buka kamera masing-masing bagi sesi bergambar. Untuk makluman semua, video seminar pada hari ini akan dimuat naik di saluran YouTube MSR. Jadi kalau mau tengok balik video, bolehlah tengok di saluran YouTube MSR ya. Okay, sebelum tu sila on kamera masing-masing. Jangan malu-malu. senang nak bangun weekend ni untuk attend webinar dan juga ambil gambar. Okay, semua dah on ke? Kami nak mulakan sesi bergambar ni. Okay, kami tunggu semua orang ready dulu. Oh, okay, ada soalan daripada Miss Najwa. Hi Miss Catherine, kalau tak register boleh ke saya baru register untuk dapatkan sijil? Okay, yang ni saya bagi kepada Encik Nur Hisham untuk jawab ya. Encik Nur Hisham, ada soalan daripada peserta kepada Encik Nur Hisham.
Apa tadi, Kat?
Ada soalan daripada Miss Najwa, dia tanya, kalau tak register, boleh ke saya baru register untuk dapatkan sijil?
Okay, so dia bagi detail. Dia kontak saya tak?
Okay, Miss Najwa, Miss kena kontak Encik Nur Hisham ya untuk dapatkan link kehadiran tu. Okay, kita tunggu bahagian teknikal untuk bersedia sebentar ya. Okay, semua ready? Senyum. Okay ya, sila on kamera masing-masing. Ada yang tak on lagi ke? Okay. Semua on, sila on. Ada yang baru nak on? Ya. Okey, terima kasih semua. Sebelum tu, jangan borodo dulu. Kami ada sepatah dua kata daripada Encik Syaiful. Ya, sekejap. Ya, jangan pergi dulu.
Okey, Assalamualaikum semua. Dengar ke suara?
Dengar, dapat dengar.
Okey. Okey, Assalamualaikum. Terima kasih pada Cik Catherine. Terima kasih pada Puan Fatin dan Puan Melissa sebagai speaker hari ini. Okey, tak ada apa pun nak cakap. Cumanya saya nak maklumkan next event kita pada 21 Mei kita akan ada AGM dan ASM MSR di Banyi. Nanti pendaftaran masih dibuka dan jemput ramai-ramai, dan pada bulan Ogos nanti kita akan ada AACRT iaitu International Conference. Semua juga dijemput hadir. Dah tak ada apa tu saja ya. Saya pas mula kepada Cik Catherine.
Okey, terima kasih Encik Syiful. Okey, akhir kata saya ingin memohon maaf dari saya dan pihak penganjur jika ada ketelanjuran bahasa, kekurangan semasa mengendalikan sesi seminar pada kali ini. Sekian dan salam sejahtera. Semoga bertemu lagi pada sesi seminar yang akan datang. Terima kasih semua.